Okay, good afternoon, everybody. I want to welcome you to this Romano round today that is put on by the Division of Collaborative Care and Wellness in our department. My name is George Nasra. I'm the Clinical Chief of the Division of Collaborative Care. And again, welcome, both for those of you who are here and those online. For those of you joining us online, I would remind you that you have the option of putting questions in the Q&A the chat option on your screen, and I will be moderating that and looking at your questions throughout the presentation, and then at the end pose those questions to our panel. Also for everybody, if you are interested in CME credits, at the end, please complete the evaluation with the QR code that's going to appear on your screen at the end of the presentation. Without further ado, I'm really happy to introduce the panelists today who are going to be talking to us about two very important programs in our division, the Employee Assistance Program, EAP, and Behavioral Health Partners, BHP. First, I want to highlight and introduce Janine Rowe. Janine is the EAP Services Manager for the UR Medicine Employee Assistance Program, EAP. With that, she leads efforts in individual and group interventions to reduce work-related trauma sequelae, provides interdisciplinary supervision, and oversees clinical services for UR employees, as well as over 75 contracts with employers throughout the region. Janine is a doctoral student in counseling education at the University of Rochester, Warner School. She is a licensed mental health counselor and a credentialed alcoholism and substance abuse counselor, CASAC. She is a certified employee assistance professional and a certified career counselor. Prior to joining the EAP team, Janine was a senior chemical dependency counselor at Strong Recovery and served as an Assistant Director of Disability Career Services at RIT. She is the winner of the New York State Career Development Association Early Career Professional Award in 2014 and the RIT Presidential Award for Excellence in 2018. In 2021, we were lucky to have Janine join our EAP team as a lead counselor, and this year, recently actually, she was promoted to EAP Services Manager. Joining Janine is Dr. Ann Cornell. Ann is an associate professor of psychiatry in the department, and since 2019 has been the director of our employer-based services, which includes UR Medicine EAP, as well as Behavioral Health Partners, BHP. Dr. Cornell completed her undergraduate training in psychology at the University of Rochester prior to her graduate school training in clinical psychology from the Illinois School of Professional Psychology, Argosy University. She then completed a postdoctoral fellowship in primary care psychology here at URMC, where she served as chief fellow and received extensive training in marriage and family therapy. Dr. Cornell completed an additional postdoctoral fellowship in interdisciplinary geriatrics and has strong interest in interdisciplinary collaboration, obviously. Over the past several years, her work at BHP has been devoted to working with employees in healthcare systems, as well as other industries, and to developing innovative ways to bring value through addressing the behavioral health needs at the population health level. I'm also, it's also my honor and privilege to introduce Dr. Shand, Jessica Shand, who is joining the team today as a panelist. Dr. Shand is an associate professor of pediatrics, health humanities, and bioethics. She received her MD at the University of Buffalo, pediatric residency training here at URMC. and fellowship in pediatric hematology oncology from the Johns Hopkins Hospital and National Cancer Institute. Dr. Shand currently cares for patients in the pediatric complex primary care practice and provides expert consultation for patients with hematological conditions. Dr. Shand holds a joint appointment in the Department of Health, Humanities, and Bioethics, where she serves as the Bioethics Pathway Director and does research at the intersection of ethics, health equity, and spiritual care. For the past 2 years, Dr. Shand has served as Director of the URMC Clinician and Faculty Well-Being Group, bringing an interdisciplinary lens to improving clinician well-being through innovations in technology, technology use, and team debriefs. She was recently named Associate Chief Well-Being Officer for URMC. So welcome to all three of you, and the floor is yours.
All right, I'm told we have a number of slides just to get through for the fun of it. Okay, we included our disclosures simply to say that we have none. And our main objectives today are pretty straightforward: to take the time to describe the evolution of our employee assistance program, because we've been around for over 30 years, to recognize some of the emerging themes and patterns of employee health and well-being that we're seeing, and to understand the mechanisms that support wellness and productivity in employees. So before delving into the history of EAP, I want to take a moment to express our gratitude to the numerous individuals who've played pivotal roles in supporting our EAP. Their support has been instrumental in fostering the mission of our EAP and the growth of our program over the past 30 years at the University of Rochester and also within our community. A special thanks to Dr. Kane, who took some time on a recent weekend when I reached out by email and got a response very quickly to help provide me with some of our EAP's rich history that had been lost a little bit over time, which I'm going to share in part with you today. So, history of our EAP. Employee assistance programs, or EAPs, as we call them. We've had a lot of different names over the years, so I'm just going to call us EAP. We came about as a byproduct of occupational alcoholism programs that developed in the early 1940s and concentrated on helping employees with alcohol problems. So that's where we started. There was a problem, there was a need, a program developed. In the mid-70s, the focus of these programs expanded and began to provide support to employees with mental health and family problems in addition to addiction. So given the many stressors that employees have faced over the decades, it's not surprising that this type of support was soon woven into the benefits of many corporations, universities, hospitals, agencies throughout our country, and actually became a requirement for all federal agencies. So an employee assistance program is woven into the fabric of most workplaces, but it can take a lot of different shapes and forms depending on what the program is. To give you a sense of the scale of EAP programs in our country, a 2021 survey by the Bureau of Labor and Statistics found that 84% of large employers in the private sector had an EAP, and 90% of large public sector employees had an EAP provider. So when combined, that means that in 2021, about 74 million workers in the United States are estimated to have access to an EAP. So I think in a day and time when it can be so difficult to access support and mental health care, there are a lot of employees that have access to this vital tool. We do think that this number is expected to have grown over the past few years as the needs of employees have been more widely recognized. So our EAP has its humble origins in 1996, so a long time ago. At the time, Dr. Eric Kane, our former department chair, was cognizant of the need to dismantle the perceived ivory tower barriers surrounding our department services. And he recognized the necessity to bridge the gap between mental health services and needs in the community and not just exist as a separate entity. So given this, when the Rochester Police Department issued a request for an external EAP service in 1996, Dr. Kane saw the opportunity to develop an EAP that could meet this need. So he solicited the support of Jack Herman, who was serving as the coordinator of consumer and community affairs in our department at the time, and had expertise in crisis intervention to help him develop an EAP service for the police department. And that was actually our first external contract in 1996. Given this, this initiative was so successful in that first year with the Rochester Police Department. By the end of that year, we'd taken on the Rochester Fire Department as well. We actually continue to hold both of those contracts to this day. So fast forward to 1998, Dr. Kane successfully advocated for the creation of an EAP at Strong Memorial Hospital through close collaboration with the HR department. So in 2001, so 1998, we started what we call an internal EAP, meaning we worked here and we provided services for employees at the university. And then in 2001, they brought on a woman by the name of Joanne Dermody to the EAP leadership team with the goal of expanding EAP's reach into the community even more. So during her years with the EAP, she successfully grew our service to have 55 external contracts. So we started with one external, we started working with the U of R, and then we expanded to have 55 external contracts. Beth Danahy, who many of you might know, took over as the director of our EAP from 2010 to 2019, during which time our services continued to grow and thrive under her leadership. So as Dr. Nasra mentioned, in 2019, under his leadership and guidance, I assumed the position of EAP director. I already had BHP under my belt and was somewhat familiar with employer-based services, and then took on over with the EAP. And have worked really hard to maintain the excellence of our services, to foster the community partnerships that are necessary, and to strategize for future growth of our program. I can honestly say that I enjoy my work, which I think since we work with employees, I can say fairly, a lot of people can't say. And that's largely in part due to the amazing people on our leadership team with whom I have the privilege of working with. So Dr. Nasra already noted Janine's recent promotion to our EAP service manager, which is amazing. And I can't say enough about the level of expertise and professionalism she's brought to our team over the past few years. And additionally, Vanessa Mace, who's here also, our current division administrator, has played a crucial role in advancing our EAP program over the past 6 years. Her skills have been instrumental in enhancing our operations and extending our reach. And she's also taught us all how to be a lot more organized, which we needed. So it's helpful. All right. So at this time in total, you can see at the bottom of this, in 2023, our EAP, we are currently responsible to providing support to well over 100,000 lives. That's a lot of people when you talk about a sort of population-based model of care and being responsible for any of those individuals that might call us on a given day. This includes employees, and it also includes any members of their households at the University of Rochester, as well as 75 external organizations throughout our region. So it's a lot of people. All right, so maintaining 75 external contracts is not an easy feat. I don't know about you all, I didn't go to school for business, and I certainly didn't know how to manage external contracts. So this has been a sharp learning curve. These external organizations are located throughout Monroe County, and they include a variety of employers, such as first responders that I mentioned, educational institutions, nursing homes, law firms, electrical unions, construction companies, you name it. We even had a boating company for a while, which was fun. We were hoping to do presentations on a boat. As you can imagine, managing contracts and working with so many different organizations involves a combination of administrative, clinical, business, and customer service skills. We support so many organizations throughout the county that we frequently find ourselves immersed in crises that affect multiple entities that we support simultaneously. This positions us uniquely, I think, to comprehend community-wide stressors that are going on and the needs of employees. So in order to do our job, we actually have to navigate dual relationships, triple relationships, quadruple relationships on a daily basis between employers and employees, and remain attuned to the individual employer cultures with distinct stressors and diverse employee populations. So it's not an easy feat, but having a lot of training and systems therapy has helped in more ways than I thought it ever could. Okay, so you might be wondering, how big our team is, given that we support so many lives. So this is our wonderful team with all the pictures they didn't want me to put up. On the clinical side, all right, so on the clinical side, we are fortunate to have a group of counselors and a care manager with a combined over 60 years of experience working in EAP setting. That is a lot of experience. I wish I could claim the majority of us have that experience, but most of it actually goes to Sigrid Adler, who has worked with us since EAP started and just hit her 30-year mark. So we have to give her due credit. But combined, it's still really impressive that we have 60 years worth of experience. This level of experience is important because the role of an EAP counselor is unique and requires clinical skills and expertise that are often outside of what we are typically trained to provide. Our counselors have to be well-versed in evidence-based treatments for individuals, for couples, and for families. They have to be adept at presenting quite a bit, teaching to a wide variety of employees across diverse settings and circumstances, inside, outside, you name it, we've done it. And they need to have expertise in the provision of crisis services for individuals and for groups. Additionally, our counselors must possess considerable flexibility and what I would call an affinity for navigating emotionally charged and often complicated situations with confidence and poise, because we get called to go out anywhere, at any time, any day. And our counselors do a phenomenal job of doing that. If anyone is listening and thinking, I know someone that would be a perfect fit for that job, you'll notice we have a vacancy, so let me know. So on our administrative side, this is our team, and we have been growing as the program grows. Equally vital to our team are our administrators. I'm sure I don't have to tell this to you all, but we can't function without our administrative component. Given the complicated nature of our services and the constant array of scenarios that come across our front desk, our administrative team in particular has strong organizational skills, people skills, flexibility, and the ability to adeptly manage what we like to refer to as organized chaos on a daily basis. So, having gained an understanding of the evolution of our EAP and a little bit of information about who our team is, let's turn our attention to the overarching needs of the employees that we support, which are the purpose of our existence, of course. So in 2022, the US Surgeon General released a framework for workplace mental health and well-being. I don't know if any of you got a chance to read this, or if you're a dork like me, but it was a good read. This response demonstrates recognition of the profound impact that work in the work environment has on both physical and mental health, and also the increased awareness of employers and our country of the need to support employees and not just tell people to keep trying or to try harder or to breathe or to meditate their way through it. During the pandemic and its aftermath, employees have reported significant stressors, and there's been a notable rise in mental health concerns, which doesn't surprise anybody in this room. This has compelled employers to prioritize initiatives that support well-being and foster a healthier work environment and culture. This has also pushed us as EAP programs to do a better job demonstrating the efficacy of our interventions because the market's becoming more competitive, right? Okay, so a little bit of data for you. In the EAP world, one way that we measure outcomes and demonstrate efficacy is by using a standardized self-report measure called the Workplace Outcome Suite, or the WAS. The WAS is a psychometrically validated measure that was developed specifically for use by EAPs to assess the impact of our counseling services on the individuals that come to see us. It's a self-report measure, and it measures change before and after the use of our counseling service. An important question for any of our services to ask is, how do we know if what we're doing is actually working, right? So for example, how do we know that engaging in EAP counseling services can have a positive impact on, and this is often what employers hire us to do, make it so that their employees can get to work, be on time, and do their job. And we're actually asked to use that verbiage some places that we go, because that is our role. We are here to make sure that everybody can get to work and be well. So in 2021, the Workplace Outcome Suite annual report, WAS scores were collected at the first session and then again about 90 days post, or as close as they could get, from 47 different EAP sources across the country. So results show that individuals that engage in an EAP counseling service reported improvement in the following areas, and these are actually the specific questions that are asked. So work presenteeism, not being able to concentrate on work because of personal problems, was reduced from 56% to 30%, which is fantastic. And again, this is seeing somebody for 1 to 5 times, right? That's the type of an impact that we're able to have. Work absenteeism, hours missed from work during the past month due to personal concern, was reduced from 43% to 15%. Work engagement, so not being engaged in work, was reduced from 31% to 23%. Workplace distress, so dreading going to work is the way they define that, was reduced from 23% to 15%. And then not being satisfied with the overall life was reduced from 37% to 16%. In reading up on this literature, this surprised me, and maybe you guys can guess in your head, how many hours per month a typical employee loses to work presenteeism. So being at work but not concentrating. Anybody want to take a guess? Average per month? It's 23.5 hours per month. That's a lot. Don't tell your boss, but that's a lot of time that apparently we're not working. Or maybe they don't work here because I don't think I have that much free time. So over the past 2 years, we've been in the process of transitioning to and really working out the kinks of a new record-keeping system. We do not use e-record. There's pros and cons to that, but we have to use a different record-keeping system. Given this, we haven't been able to collect the WAS data of our own on a consistent basis. However, we have been able to collect general feedback from clients about our services. And as you can see here, our clients generally think that our services are helpful in addressing their concerns and maintaining their work performance. They would call us again in the future if needed, and we're satisfied with the referrals that we offered and would recommend our services to others 90% of the time. I think these scores are exceptional, especially given the fact that so often people come to us with a misconception about what we do. So it's our job to provide education about what we do, help come up with resources, give brief interventions, and then we're responsible for helping people try to navigate the really complicated system that is mental health in our community. So for us to have scores this high, I think our team is doing a really, really good job. All right. So at this point, I'm going to hand it over to Janine to talk about sort of general utilization rates for the University of Rochester specifically, and the types of services we provide through EAP. Thank you.
Thank you. Okay, so another way that we can understand our efficacy is to understand the numbers of employees that find their way to us, okay? And so we measure EAP utilization, how many come to us in a given year. So you can see average across EAPs in the United States, holding steady around 5%, except for in 2020, when it was a bit higher. And the University of Rochester utilization, as you can see, is much higher than the national average and trending increasingly. So when you look at that graph, you may think, is this group of employees disproportionately distressed? Is there something going on to why so many people are coming into the EAP? Part of how we understand that number is a couple different ways. It gives us information about our program, and it gives us information about the organization. So high utilization means people can find us. They know who we are, they know where we are, they know how to get to us. They're coming either through scheduling an appointment within 3 to 5 days. They're scheduling a same-day crisis appointment. They're speaking with the on-call counselor on a holiday or a weekend or in the middle of the night with a crisis. Right? It also speaks to employees that feel empowered to take steps to take care of themselves. They're speaking up and asking for help. It lets us know also that our program, as I had mentioned, people would recommend us to others. People do come back in subsequent years when another maybe life transition shows up, and they come back in later years. And this also lets us know managers and supervisors are talking about mental health, and they're referring to our program. And as we're going to see in a little bit, a lot of employees expect their supervisors and managers to be knowledgeable about mental health resources, and they're going to their manager with these concerns. Okay, so again, they're sending them to EAP as they should. Okay, and another point about utilization that Anne mentioned, as stigma around talking about mental health and stress and burnout is reducing. Probably one good byproduct of COVID, that we're talking about this more frequently with less stigma. So Dr. Cornell told you the history of the EAP, and I get to tell you the present, and tell you about our 4 branches of our services that improve employee health, productivity, and engagement, and create spaces for people to fall apart. You're going to see a qualitative shift in our philosophy. So we're no longer doing single problem identification. We're no longer just identifying individuals with alcohol use challenges in the workplace. We are doing intervention, promotion of various wellness topics, and crisis intervention across a pretty boundaryless scope of employee and organizational problems. And also quantitatively, we've changed as well. So we're not doing just that single intervention. We are working with multiple different services to capture the needs of the organization. So starting with counseling, this is our bread and butter of our program. So our voluntary, confidential, short-term counseling, usually 5 sessions or fewer, and working with individuals and their households who are employees, and doing couples work and family work, okay? So within those 5 sessions, there's actually a lot that we can do to help somebody feel better. So we are going to start with that biopsychosocial assessment to understand the scope of the current problem. We are assessing for safety concerns, and often in that first meeting, we are talking about fears that that employee might have about engaging with mental health services at all. And there may be stigma and fear about getting into counseling. We do a lot of referrals and recommendations, so our counselors have to be continuously aware of the quality and availability of resources in the community that are related to mental health, to childcare, to psychiatric care, to legal resources, financial supports, and it goes on and on. We are not a replacement for mental health therapy. We don't see ourselves as competing for that space at all, but rather we are a complement to those services and a bridge. So for a lot of folks, we are the very first place that they come, saying, I don't feel like myself, I'm not sure what to do. And through that assessment and short-term counseling, we can work with them and get them connected to those necessary supports if they need, BHP or additional services. About half of our clients will accept a referral, and the other half will finish up within 1 to 5 sessions. So not everybody needs to be accepting a referral out. There is such a wide variety of concerns that an AP counselor may see in a day. Their first appointment may be working with an adolescent and their parent, trying to develop some healthy routines for their screen time. The next appointment might be meeting with an employee that was just terminated from their position, and they need to talk about what life looks like in the coming weeks. Their third appointment could be a crisis appointment with an employee experiencing a new onset of psychosis. So it is never boring. And rather than try to present to you a comprehensive list of all the types of clients that we can see, we are prepared to show you 3 composite cases that represent trends of what we're seeing recently and give you a sense of what we would do with that employee. Okay. So our first vignette relates to an employee who's experiencing an erosion of their well-being due to their work stress. This is somebody who, they may say, I can't believe I'm thinking of taking early retirement. I've been in this job, I've loved this job, but I don't recognize it anymore. They find themselves working more and more, and also saying, if I don't do this, who will? There's no one else that can help me or pick up where I might do a little bit less. They are increasingly feeling underappreciated and undervalued in their work. So this is not a problem of insufficient bubble baths and pedicures, although we have nothing against those things, okay? But this is probably a type of client that's wanting to go deeper and not just review individual self-care strategies, but understand the root causes of why they're feeling the way that they are and change the current trajectory that they're on, because they can't continue in this way. So what we would do in potentially 5 sessions or fewer is understand a little bit more about the situation. So how is stress showing up for this employee? Are there comorbid concerns with depression or substance use? Are there health-related concerns that are connected to the stress? We're going to work on some coping strategies that this employee can use like in the immediate, right? So for an example, that might be working on a misattribution, understanding that the current way that they're feeling is a result of the pressures of work and not a personal failing and not a lack of skill. Okay? So we help people to take care of themselves while they take care of others in really challenging work. Okay? So work-related trauma is another common presenting issue to the EAP. And I know, and we know that work-related traumas and work trauma exposures cannot fully be prevented in this work. They can be a part of the job, and counseling can help people make sense of that experience and to recover. These traumas can show up in a lot of different ways. So just to give you an example, let's say an unanticipated patient decompensation or patient code. That's going to impact the clinical team that provided care, but it's also might impact the OAS that answered the phone when that patient called. It's going to impact environmental services team that provided cleaning to the room after the trauma had completed. It's going to impact medical interpreting who spoke to the family after the event. So a lot of ripple effects. If these traumas are not addressed and that person doesn't receive support, we see a couple different things happening. So one is fear. People start to avoid, and you've seen this quote, I'm starting to avoid certain aspects of my job because of the traumatic recollections. I'm avoiding talking about this because I'm worried that I'm going to get sued. I'm worried I'm going to get fired. People are judging me. Right? Deeply isolating experience. And if this continues, to not be supported and addressed, people will consider, did I make the right choice of profession? Should I leave? And I worked really hard to get here, but I don't know if I can continue. Okay. So what does brief intervention with this type of employee look like? You'll be familiar with them. It's a lot of our grounding skills in psychoeducation, normalizing the response that they're having. And often that can be working to create a coherent narrative in their life with the event. And this is somebody that we want to monitor to see, are they developing some symptoms of post-traumatic stress disorder and in need of ongoing care. Okay. And lastly, employee for whom depletion has become their normative state. Right? This is somebody, often they'll come in and say, my supervisor gave me this EAP card, and sometimes they bring it and kind of hold it, as their ticket in. My supervisor gave me this. I don't really know how you can help me, but they said I need to come and see you because I let them know I'm struggling. Okay, so this is somebody that says, I don't feel like myself, but I also don't think that anything's going to change here. I don't enjoy or find interest in my work. Team cohesion is breaking down. We hear a lot of people that say, my work environment has become one of mass negativity. I'm feeling criticized. I find myself criticizing other people. I'm feeling abandoned by my organization. So real depletion of their natural resources that previously kept them connected to the work. Now, what do we do with an employee for whom their concerns are related to the realities of their workplace, the realities of low staffing, of lack of resources, of high workloads? The first thing is, what are the factors that are under your control? How can we concretize the steps that you can take to feel even 1% better? How can we work on some non-reactivity or cognitive diffusion skills so that you can be present to your challenges without feeling totally engulfed in them or lost in them? And how would you know if you're feeling better? What small changes would we be aware of? Would we see? How would we know if you're getting worse? And what do we need to do to intervene so that you don't start going down path of feeling worse? Okay, so And with this audience, I know, like we know these skills, strategies, and intervention, use them every day. And sometimes it's difficult to apply them to ourselves. And we enjoy partnering with employees to help them be connected, again, with those positive coping skills that help them stay in their job and feel better fast. Okay. I'll tell you briefly about our education. So our education extends our reach of individual counseling. And I think this is part of a cultural shift around well-being. That well-being is not a set of individual behaviors that we do when we get home from the job or on the weekend. Well-being is a collaborative effort between the organization and the employee. So we work together. And our education intervenes at the team level and the organizational level to provide some of these skills. Now, again, I couldn't give you a library list of all of our offerings, so I just picked some of the most popular topics this year. Our group wellness workshops, we're coming to your retreats, we're coming to your team meetings, to your education days, to recognize challenges in communication, conflict, stress associated with changes. You experience them as a group, and it makes sense to talk about some strategies to alleviate them in a group. And we'll provide about 100 of these workshops per year for the University of Rochester. Our supervisor series recognizes that supervisors and managers are critical to well-being of employees because they're often the first to know and the first to be in a position to respond to an employee that's really struggling. Okay? And so we want to give them a framework and some language to understand, my employee is texting me, I won't be in because this will be my last day living. Right? We want to be able to give that employee or that supervisor the ability to respond quickly with support and know language and framework for that. Okay, and lastly, Health Bites, our blog, newsletter content, just in good recognition that leisure and hobbies are an important part of wellness as well. And so we are able to partner with our community experts to provide these workshops monthly. Our critical incident response is a crucial aspect of emergency plans here at the university. And so, as I mentioned, trauma exposure is not preventable, but mitigating of traumatic effects, this is something that we can do with our critical incident model. And the goal is to start to take proactive steps to begin to recover safely with peers. This is an evidence-based intervention that helps to reduce emotional distress. And most people are familiar with a debriefing as a form of our critical incident response. That's actually like the end. What happens first is consultation with leadership when a crisis occurs, right? And it doesn't always look like a debrief. It could be a supervisor calling and saying, I just received notification that one of our team members passed away unexpectedly. Can you please help me craft a message to the team that is, what information should I include or not? How can I make sure people can find their way to you? Or the consult could be, how do we structure a debrief for interdisciplinary clinical team when a medical catastrophe occurred? And there's a lot of really intense feelings, anger, and worry about the event. Okay, we want to do that safely. Okay. So luckily, we are not alone as an EAP in doing this. We partner with about 28 very skilled volunteers here at the Med Center who are trained in critical incident responses and debriefing. This increases the flexibility and responsiveness of the service. And we're working on how we can extend this program to our affiliates with the University of Rochester because they're very interested in learning how to have this layer of support. Our debriefing service, I want to just say, is not a trauma processing or trauma reprocessing session. The goal is to have a single session to help mitigate the adverse events of that trauma. And so we also about 100 of these per year between EAP and the UR support volunteers, but really innumerable numbers of team huddles, one-on-one consultations. Our volunteers might approach somebody one-on-one that seems to be struggling with an event. So it's really difficult to capture that work, but I just want you all to know that there is a small army of people who are very well equipped to provide this type of support to their peers. So a couple of trends that I want to draw your attention to, what we've seen so far this year in terms of crises that we've provided support. The first, and it won't be any surprise to you all, people are feeling unsafe and overwhelmed with the work that they're doing. And when that happens, not only are they dealing with the stress or trauma of that acute event, they're also often left with feelings like, well, I should have been able to prevent that. And if I couldn't have prevented it, I should be able to get over it very quickly. Or they may feel like nobody else is bothered by this, only me. Okay, so really important time to provide some support and intervention. Grief and loss is another theme that we're seeing. Just, many teams, unfortunately, in the position of losing a team member this year, especially sudden and unexpected losses that are quite emotionally distressing for folks in ways I'm sure you can understand. I'm so encouraged to let you know that a trend we're seeing is an increase in discipline and unit-specific efforts around critical incident stress management. When you need space to fall apart, probably you look to a peer. I know I do. Okay, and so the more that we can have pods or groups of people that are armed with these skills, the more opportunities we can provide for people to feel supported in this really tough work. Touch on briefly what this model looks like and what the peers are trained to do and what the EAP counselors do. Critical incident stress management is an evidence-based model. It's used by the ATF, it's used by the American Pilots Association and other organizations that have near-miss events and traumas. Okay. So we start wanting to just facilitate recovery and resiliency. We have a framework for what do we do right after an event occurs? How can we check in on people? And with that, demobilization is a really quick gathering to see if everybody's okay. Does anybody need help? And can we get them help? Before people go home for the day, we want to huddle once more, excuse me, to reinforce calm engagement and to help people start thinking about proactively coping with that event. Once we've done those two steps, then we start thinking about, do we need a debriefing, okay? And teams that demobilize and diffuse reflexively and frequently find that the debriefing is less needed because people are able to talk about things and process things as they go, okay? People naturally seek out affiliative connections during times of crisis, so this model helps structure those conversations for staff. We're really, really proud to have 1,800 of our peers trained in what to do right after a critical incident occurs and at the end of the day. Okay. We are even more proud that we have 130 people so far who are trained in all three steps, including facilitating a debriefing. And so, like I said, there is a small army of people who are able to provide this support after a trauma. Okay, and lastly, I want to briefly touch on our consultation and collaborative efforts to provide mental health education to our peers. And there's just a couple of highlights of our collaborative efforts, how we work together. The first is with SafeSide Prevention, and we're working with SafeSide to develop a framework for how to use this model when we are supporting an employee who's in crisis, but they're at a distance. Maybe they're in another state, okay? And the supervisor is aware that somebody may be having thoughts of harming themselves or someone else. Okay, maybe they see a text message or a social media post. How can we use the Connect and Extend framework to provide support not only to the supervisor, but to that employee that may be at risk? So this model is actually being adopted by other EAPs who are also supporting supervisors in these what can be tense moments. We also have significant collaboration with graduate medical education to provide support to residents during their pivotal moments. One of those pivotal moments is in the beginning of training, our wellness check program that offers residents the opportunity to forecast what are the personal and professional stressors I'm likely to experience in the next year, and what will I do to take good care of myself if they occur. We also have a procedure for a voluntary reflexive meeting with an EAP counselor in the event that a resident receives negative feedback about their ability to progress in the program. Because those can be life-changing conversations, we want to be able to provide immediate support. We've figured out a way to do that. Okay. And lastly is working together with institute-wide well-being initiatives, which there are many. You're going to hear about what that collaboration looks like in a minute. Before I turn it over to Dr. Shand, I just wanted to point out, we received some feedback that I think explains the nature of our collaboration better than I could describe it to you. And this is related to work that we've done with Dr. DeCaprelli-Ryan in surgical residency. So she's let us know EAP helps us recognize everyday stressors that clinicians face, the moral distress that we encounter, reflect on what we need, normalize discussions while helping recognize suffering should not be normative, identify those in distress, and develop language to navigate those difficult conversations. So with that, I will turn it over to Dr. Shand to describe our connection with initiatives at the university.
Thank you so much, Janine, and thank you to both of you for inviting us here. I'm really here as an embodiment, symbolic of what has started and will continue as an incredibly fruitful collaboration between those who are thinking about well-being at the organizational level, and where EAP, and particularly the skills, the tools, the education, the implementation of the UR support team and critical incident response fits into that. So I'm just going to very briefly share some goals, but also vignettes with you, because when we think about and we tackle this complex problem of clinician, healthcare team, affiliate, burnout, depersonalization, loss of hope, right? There are factors that are beyond any one institution to control, labor forces, other things. There are systemic factors within the institution that are absolutely in our control. And then there needs to be sort of thoughtful prioritization of what interventions are going to be felt most quickly and most meaningfully for those where they need it the most and when they need it the most. So, our institutional goals, I'm just going to tell you, is, to continue to do a better job assessing our landscape for how folks are doing. And I'm going to get to, there's a connection between some of our institutional and local surveying, both of our trainees and our frontline healthcare force. And I will tell you the one variable, the one piece of feedback in all of our surveying, and there is no one perfect survey except frontline listening conversations, but we'll give, this isn't about the qualitative research aspect of it, but folks are asking for more and better opportunities to debrief critical and traumatic events in the workplace, whether that's areas that increase chronic high-level traumatic stress, like the emergency department, CPAP, some of our perioperative areas, where this work started for me in the pediatric critical care and intensive care setting, the ambulatory setting. So I also work in ambulatory. We're seeing increasing incidences of violence, threats, understaffing, all of the things that everybody here already knows. But when we really take a deep dive into well-being index data, local data conversations, the one theme that comes across is teams want more opportunities to debrief. And in that, more skills to handle and cope and improve adaptive coping. And so then the question becomes, how do we improve access and how do we implement in ways that are durable? And how do we prioritize that and normalize it, particularly in cultures where that expression of the need for help and of vulnerability is not only, just could be discouraged, but for a long time has been institutionalized against. And so I'm going to share with you the 2 areas of the hospital. These are just examples where our collaborations with UR support and critical incident response are just sort of examples and embodiments of how we can fulfill that goal of getting people, education, and tools out to where people need it the most. And so I'm not going to go through this slide. You can sort of look at it as I'm speaking as a reference point. I want to be mindful of time. But again, just to emphasize with you, if you take one point home from this part of my presentation, it's that a strategic collaboration with EAP and UR support to amplify and improve access to critical incident response is a major institutional priority. And so the question that often comes up is logistics. So for example, we started our pediatric residents really reached out to us and said, we need more opportunities to debrief unexpected patient deaths, right? You can have all the training in the world. The first time a child codes and dies on the table, there is nothing that prepares you for that. The team for that, as our colleague said, EVS, who was in that room the whole 2 years that child was receiving chemotherapy, got to know the family. How do we bring teams together? And often we found qualitatively there's a reluctance to bring someone in from the outside to do a debrief because they may not know the culture, they may not know the people. And so our goal really was to overcome that by identifying the most strategic and continuous people to receive level 1 and level 2 UR support critical incident response training. At the Children's Hospital, they were our nurse managers, some members of our palliative care team, and we essentially partnered with UR support training to create a more comprehensive pediatric debriefing service that folks could ask for whenever they felt they needed it, but certain automatic triggers, an unanticipated death, a code, a transfer to the ICU, just certain things would automatically trigger that. In order to make it happen, we have to have people trained with the right information, with the right skills, and that's where UR critical incident support was so important and continues to be. Another example is in the perioperative space. So this isn't a criticism, it's an observation, but surgical culture and the culture of the OR is a very difficult place for someone to stop after an unanticipated event and say, I'm struggling, I'm suffering, and I don't think I can continue without a debrief. There are just many things in the nature of that work and in the culture that discourage against that. And so as part of our institutional well-being group and our perioperative interdisciplinary well-being group, for which Dr. DeCaporal Ryan is a member, and others, we talked about and implemented now. There are 16 nurse managers, CRNA leaders, and physician leaders in the peri-op space who are trained in level 1 and 2 training. And we just had Janine and Ann were at a peri-op grand rounds with an external speaker last week talking about critical incident debriefs specifically in the OR and how we can learn from that experience and use the tools of UR support and critical incident response to improve adaptive coping, to reduce depersonalization, and potentially reduce medical errors and toxic culture in the OR using those skills. So these are just examples of how the priority at the institutional level is to address this call for a need for better debriefing and team support after critical incident and traumatic events. Does that mean we stop fighting for the systemic things that are causing the distress? Absolutely not. But there aren't going to be 600 more staff members tomorrow. So we work on what we can build and what we can reinforce. And then another implicit outcome, in addition to improved adaptive coping and workforce engagement, is that we start to normalize a culture of debriefing. We normalize a culture of asking for support. So the resources, the expertise, and the training of critical incident response, UR support support and EAP is really just going to be vital to this work moving forward. And I'm here to tell you it's an institutional priority, and anybody that has feedback about how we can continue to make this collaboration bigger and better, all of it is welcome. I'm going to hand it back to Dr. Cornell. Thank you.
We're enjoying that we're all the same height. So this is working out really well for us. All right, so I'm going to wrap this up. I hope you're all familiar with our department strategic plan. It's important, and we should be aware of it and make sure that what we're doing is in line with it. And we do spend a lot of time, Dr. Nazir, George, Vanessa, and myself, and our team really strategizing. I think EAP is a key player, and not only because we have opportunities and a responsibility to grow to meet the needs of the community, but also because we have a responsibility to demonstrate that on our own teams as well. And we put a lot of time and effort into making sure that we're practicing what we preach on a real level, so that when we go out and we present, we're not being hypocritical. So we do have a lot of strategic goals around making sure that our counseling services are flexible, that we're embracing the reality of education these days. We change our topics as we need to stay in keeping with the time. We've talked a lot about critical incident responses, but we do want to grow and diversify our peer support programs. And we really want to make sure that we are the EAP provider of choice in our community and region, not just because we like having more contracts, but because I think we do a good job. And I think when you compare us to other types of EAP type programs that are available now, we are boots on the ground and we're actually here doing the work one-on-one. And we want to make sure that employees are getting the support that they need, because we know it makes a really big impact on everybody's ability to get to work and to do their job, which is what the goal is on a really sad base level. So we're running a little bit short on time, but we're happy to take questions, and then we're happy to hang out after if anybody has any feedback or questions that you have. Sorry, that slide's important.
Any questions, anybody in the room?
Hello. Okay. So of course, you guys help a lot of people in terms of mental health across the board. And so how do you guys support each other within your department? Because obviously, people deal with a lot of different situations, but you guys specifically deal with the broad of a hospital. And so how do you guys support each other or support yourselves in mental health to prioritize your own well-being so that you can do your job effectively and support us?
I love your question. I'll answer briefly. One of the most impactful things I think we do as a team is we debrief our debriefs reflexively every week. And people have come to rely on that as a time to get support from their peers and talk about, because debriefing is challenging. We're going to areas where a trauma has just occurred. And we've come to rely on each other for that support. Thank you.
Yeah, I would amplify that peer support and debriefing the debrief. So even folks who are involved in that work who may not be part of the primary infrastructure of EAPs. So whenever we facilitate debriefs, we always make a little bit of time to debrief the debrief. And again, other informal ways of providing peer-peer support.
Just wanted to comment off what you said. I would, and on top of that, one of the goals you had for other departments to be able to debrief, that, if you guys are able to, and you guys fit it in, I would love to see other departments fill it in as well as a priority and as a part of the job, because it is important, and you can't do your job and then you have people leaving their jobs or losing their jobs because they just can't handle what's going on. And so, yes, connecting with you guys, but especially connecting with people in the department, because they're going through it every day. And so they understand more than anything what they're going through and how it feels. So I would love to see that implemented, like what you guys do in your schedule. I'd love to see that implemented in other departments.
Yeah, a huge part of that discussion, that the logistics of that is so important. And it's really an inclusivity issue as well. And so what we've been challenging and asking folks to think about is think about your daily work naturally when people gather. And so that conversation we had in the OR, because of course, when we presented some of these, even though they're done at other institutions, we presented some of these methods, to OR leadership. And of course, the question was, even if something bad happens, we got to turn that room over and get the next case in. And then at 7 o'clock at night, everybody wants to go home. Well, if there's an unanticipated event, there is always a safety checklist, and a debrief, a clinical debrief afterwards. What if there's 2 minutes worth of a welfare check and that gets integrated in? And so those are the conversations. Is it your huddle? Is it your safety check? Where is it in your daily workflow that we can normalize these practices happening? And that's the question we want everyone to answer. And then we're ready to come in with the tools. So I'm so glad you mentioned that.
Thank you very much, Jessica, and Janine and Dr. Cornell. And you offered to stay afterwards if anybody have any more questions, but thank you for this wonderful presentation.
It's so nice to see how far you've come. I'd like to hear about PHP next time.
Yes, thank you.